I'm Carlene Muto. I'm one of the hospital epidemiologists here at the University of Virginia Medical Center. I am in the Division of Infectious Diseases and Infection Prevention, and C. difficile is one of the organisms I study.
Hello, my name is Scott Curry. I'm an assistant professor of medicine in the Division of Infectious Diseases at the Medical University of South Carolina. I've been involved in some way or other with C. difficile research for 16 years and counting.
So C. difficile isn't a ubiquitous pathogen, which means it's found all over. So we see it in the environment and all kinds of places, but it can get into the hospital, and when it does, it becomes a major reservoir for hospitalized patients. And about 20 to 40% of the patients who are in hospitals actually have C. difficile, perhaps just colonized, and then some are infected as well. And so the incidence has always been described as about 5 to 10% of the folks that come into the hospital, end up with C. diff disease. That said, over the last decade, we've seen a striking increase in the number of C. diff cases. And in fact, from 2000 to 2010, the incidence has doubled in the United States hospitals, and in Canada, it's tripled. So C. difficile, although it used to be sort of just a nuisance pathogen, is not only increasing in numbers, it's also becoming more problematic in that it's making patients sicker. Length of stay has increased from about 3 days to nearly 6 days if you have C. difficile. The costs of these infections range between $3,000 and $15,000 per episode, with an annual cost to U.S. hospitals of nearly $5 billion. So we're really seeing lots of new activity with C. difficile, probably because there are emerging pathogens within C. diff, newer strains that might be sort of accountable for why we're seeing more problems with more severe sickness and that sort of thing. That's clearly what's been happening. As far as mortality, so patients die of this. And so in 2007, we've seen about 14,000 deaths due to this infection. And it's now actually the #1 hospital-acquired infection in the United States. And by 2011, the number of cases in the United States was about 500,000 with 29,000 deaths.
So hospital-acquired C. difficile and community-acquired C. difficile have a bit of a gray zone between them, and that's community-onset C. difficile. And this is a difficult epidemiological concept. In the definition of C. difficile infection, we have to understand that we don't know the incubation period for the organism. So we have two contrary strains of evidence for how long that incubation period is. One is we know that patients who check into hospitals who are negative when they check in by culture, they are at higher risk for getting C. difficile than a patient who comes into a hospital and already carries C. difficile with them. And that is counterintuitive, because it's always in the mind of everyone that C. difficile, being antibiotic associated, results in overgrowth of C. difficile when the other bacteria in the colon are killed off by antibiotic use. That does not appear to be the case. From the studies that were done in the 80s and 90s, we know that patients who come in with C. difficile in their stool are actually at reduced risk for getting C. difficile infection. And the patients who go on to get clinical infection, they appear to pick up their C. diff by rectal swabbing studies only a few days before that symptom begins. The other end of that evidence, however, is that we see patients discharged from the hospital continue to have C. difficile infections diagnosed somewhere until about 4 to 8 weeks from the time they're discharged. And their rate doesn't fall to that of a normal, non-hospitalized individual until you hit around the 4 to 8 week mark, meaning that we assume that there's an incubation period between when they've picked up C. diff in the hospital and when they actually get diagnosed with it following the discharge from the hospital. So we have the idea that C. difficile is definitely hospital-acquired in some individuals, and there's clear evidence for it. They've been in the hospital for more than 3 calendar days. They get symptoms. That's an easy diagnosis. The other side of that is if you haven't been in a hospital for the last 3 months and you get C. difficile, clearly that likely is that was an acquisition and a disease state that occurred in the community. What happens in that gray zone when you have been in a hospital in that 3 months before your diagnosis? Was that the hospitalization, or was it the physician's office, or the dentist's office, or chasing around an infant on a playground where the dirt is known to contain C. difficile. That's a large gray zone of indeterminate epidemiology that's difficult to account for by the current definitions.
So the interesting thing about C. diff is there are two types of risk factors. There are those that are modifiable and those that aren't. Now the modifiable things are the most important in a sense in that we actually might have interventions to make them not at risk. The non-modifiables, unfortunately, are things like age and certain like medical conditions and such. And so it's important to know about them because they put the patient at risk, but there's not much we can do about them. In terms of the modifiable, the most important risk factors are things that actually muck with your GI tract. And by that I mean change the flora. And so we have great bacteria in our gastrointestinal tract, which are our GI flora, and they really keep our colon healthy. When that gets altered, it really allows C. diff to have a survival benefit. And so things that do that are things like antibiotics. And I can't stress enough, it's antibiotics, antibiotics, antibiotics. And so the primary ones that historically were linked to C. diff were things like clindamycin, which is pretty much a drug of the past. We only use it now under certain indications, penicillins and cephalosporins, which are still used in healthcare. More recently, though, there's been sort of newcomers to the list. And I will say any antibiotic can put you at risk for C. difficile, but the newcomer is the fluoroquinolones. So when we first started to see the outbreak in Pittsburgh, we did a case control study and looked for what had changed. Was it the organism? Was it the population? Was it the antibiotics? What was different? And what we found was that the fluoroquinolones were being used significantly more than they had been in the past, and that was linked temporally to our outbreak. And then when we actually studied it with the case control, we found that it had an increased odds ratio of about 2, which means you were twice as likely to get C. diff if you were on the fluoroquinolone as if you were not. Now that wasn't as high as the risk of clindamycin, but because that's used only a small percentage of the time, the fluoroquinolone was actually responsible for most of the C. diff cases in our institution. So antibiotics are clearly problematic in healthcare. The other things that are modifiable are things that affect the gastric acid production in your body. And so H2 blockers or proton pump inhibitors can decrease acid production and again, changes the way that the C. diff moves through your gastrointestinal tract and puts you at risk for that. Other things are chemotherapy and really sort of mechanical things we do to the GI tract, like NG tubes or surgery, or things that disrupt the normal habitat of that gastrointestinal tract. And so those things we can really change. Antibiotic use in this country, in our hospitals, 50% of the time is unnecessary. And even the antibiotics that we do use, we can certainly pick ones that have a much more narrowed spectrum. And so instead of knocking out all the intestinal flora, they would spare some of that colonic environment, and perhaps C. diff wouldn't have that great of a survival chance. Now the non-modifiable things are things like age, and it is well known that the older you are, the more likely it is, or the higher your risk is for C. diff. In fact, after you're age 64, every year of age puts you at more and more increased risk. And the reason we think that happens is because as you age, your immune system becomes blunted, and you cannot mount the same antibody response to the toxin that the C. diff produces. And so they're the people, this has been very well studied, folks that don't have a good antibody response to the toxin are those who end up with disease. So you or I, we would get C. diff. It's a fecal oral, which means you ingest it, sorry to say. We probably wouldn't get C. diff. We have great intestinal flora and we have good antibody response. And so things like that are non-modifiable, but very important for us to maybe build preventative measures from other standpoints in which we can effectively target those types of populations. So additionally, as far as non-modifiable, there are certain conditions in which patients have that can put them at more risk. And really almost any chronic condition can do it, but the ones that we find to be most problematic are things like inflammatory bowel disease and people who are immunosuppressed, severely immunosuppressed. So things like solid organ transplant or bone marrow transplant, those patients become at highest risk. And our case control study transplantation, solid organ transplantation, had the highest odds ratio of anything studied. So those patients were 8 times more likely to get C. diff disease than anybody else in our cohort. So these patients in particular deserve some attention. And with inflammatory bowel disease, it becomes quite problematic because their disease itself has very similar symptoms. So when they're having diarrhea or abdominal pain, is this an IBD flare or is this C. difficile? They're often colonized or co-diseased, and so it makes it difficult for the gastroenterologist to really tease out the pathway what would give the patient the best resolve.
Clostridium difficile is an amazing pathogen in terms of how hardy it is. And so most of the transmission that's occurring is via spores. C. difficile spores are very resistant to standard disinfectants. As I've mentioned, bleach is required to reliably disinfect hospitalized surfaces. So unpleasant as it is to think about, it's spores going down the fecal-oral route that really results ultimately in a patient becoming colonized or infected with C. difficile. Specifically, we know that a study of mine in Pittsburgh from a few years ago showed that about 1/3 of transmissions are occurring probably directly from Clostridium difficile infected patients. So a patient we know has diarrhea, and despite all of the infection prevention practices that existed at the time of my study, we see some transmission from those patients directly to new patients. And that's occurring either because they're transmissible before they get put into contact precautions themselves when they're diagnosed, or that we're ineffectively applying infection prevention practice after they're diagnosed. Another 1/3 of patients we could directly show by molecular typing we're seeing C. diff transmitted from asymptomatic carriers of C. difficile. And these are patients that are completely without diarrhea, without any symptoms suggestive of C. difficile, and yet they are transmitting onto objects in their rooms and therefore can have it transmitted directly to them by the hands of healthcare workers. A small fraction we were able in that same study to show we're getting environmental transmission of C. difficile, so that was coming from their room, from the prior room occupant had a C. difficile that matched what the patient themselves was ultimately diagnosed with.
The most important thing is to understand how C. diff is transmitted in the hospital, because you can't build your interventions until you know exactly what's going on. And so I call this story the seed and the fertilizer. And so the C. diff organism, or spore, is the seed, and that is absolutely necessary for you to get disease. So you have to ingest the seed. Now the fertilizer is all the things we do to you. I mean, again, there's the age and that sort of thing, but while you're hospitalized, we will likely muck with your GI tract. You will likely get antibiotics, you will likely be in a hospital setting where you will be exposed to the seed, you could have surgery, there are all kinds of things that will put you at increased risk. And there's a good likelihood you're going to come in contact with the seed. So the way in which we interrupt transmission is there's only 2 things you could do. You either stop delivering the seed or you use less fertilizer. So stop delivering the seed is something that we probably have the most control over. So this would be your cleaning methodology, the way we see patients. We use barrier precautions, which means a gown and gloves and hand washing with soap and water. We use dedicated equipment, so if I'm seeing a patient with C. diff, they'll have their own stethoscope, they'll have their own blood pressure cuff. We don't want that equipment from going from one patient to the other and taking those C. diff spores with it. Now the C. diff spores are problematic because spores are hardy and they're resistant to most chemical disinfection used in hospitals. So you have to use a special chemical or a sporicide, and those things are things like bleach or hydrogen peroxide with peracetic acid, and they work incredibly well when they're used perfectly. And so you have to be, vigilant about the way that they're used. You can't just pick the right product at the right concentration. You have to make sure all the surfaces are saturated, every surface, and that those surfaces remain wet for the required contact time, which is often 3 minutes. So all of those things have to align to make sure that your room no longer contain C. diff spores when the patient is leaving the room. And honestly, when I was at the University of Pittsburgh and others, have found C. diff spores in rooms. And so again, I can't stress enough the importance of the environment and how vigilant you must be in preventing, that disease from sort of staying there and getting exposure to the next patient. The other thing you can do with the environment is to do audits. And so not only do you do all this great stuff, then you go back and you see how well did we do. And you could either use like a fluorescent dye, where you kind of dot the room and then go with a black light to see if the dots are still there. And if they are, that means you didn't do effective cleaning because you didn't wipe them away. Or you can do something called ATP testing, which is a little bit more fancy and a little bit more expensive, but both really can serve the purpose of doing the audit to identify how well you're cleaning your rooms. You can also make sure your people are wearing the right appropriate PPE, as they should, because practice and policy don't always match. And so we tell them they must wear it, and we tell them they must wash their hands with soap and water, but sometimes there's failures, and then we have to do sort of things to have improvements in those methods. As far as the sort of other things that could happen is the decreasing the fertilizer. So the antibiotics, antibiotic stewardship is also imperative in hospital settings for many reasons. But for C. difficile, it's because if you can not alter that flora as much as we do, you can put the patient at less risk for acquisition. And so the seed and the fertilizer go hand in hand, and pretty much you won't have C. diff disease, sort of if you can effectively change those two parameters. So how do we interrupt that transmission? Well, we do all those things. We want to make sure we identify all of the patients who have C. diff. So testing. It's been debated. We used to use a test called an ELISA, and it was very insensitive. It could miss a whole third of the patients who had C. diff. And so we went to this more sophisticated testing with PCR, which is fabulous. And now people say, well, it identifies more people than we want it to because we're getting the colonized folks as well as those with real disease. I don't care. For my purposes, I want them all in isolation, and they should be all in rooms where barrier precautions are utilized and sporicidal cleaners are used. Now, in my opinion, I think we should do sporicidal cleaning universally, which means not just in the rooms of patients we identify or suspect of having C. diff, but in all of your patient care areas. Because guess what? I don't know you have C. diff today, or I may never know you have C. diff, but tomorrow your lab test comes back and you have it. That environment's been contaminated, you haven't had your special cleaning and that sort of thing. And so I think that's a great effective way of doing it. As far as the testing, like I said, the PCR is really good. The caveats are only test people who you believe have disease, don't test people more than once, and don't do a test of cure.
So the conventional approach to the hospitalized patient with C. difficile infection focuses on whether that patient has initial disease or recurrent disease. It also focuses on whether the patient has severe disease or mild to moderate disease. There are several scoring systems out there to determine who's who. Some of them are more complex than others, but once you've made that decision, the treatment of the mild to moderate disease patient typically focuses on deciding between metronidazole, which is not FDA cleared to treat C. difficile, and vancomycin, which is, but comes at slightly greater expense for the hospitalized patient. The head-to-head trials in the early 80s for both agents showed no particular differences, but we saw significant advantages of vancomycin over metronidazole in a recent randomized trial, which actually studied them as two arms compared to a third agent that was actually never successful in treating C. difficile. So the recent guidelines for treatment of C. difficile have increasingly focused away from using metronidazole and toward using vancomycin, which clearly seems to be the agent of choice for patients with moderate to severe disease. Then you have to look at, is this a recurrent state or is this a first infection? There is some evidence that a third newcomer antimicrobial, fidaxomicin, may have a lessened recurrence risk if you're treating a first infection. Whether that has been accepted by hospital formularies is an open question. Tends to be focused away from using fidaxomicin in that circumstance because of its price compared to vancomycin, which itself is not inexpensive once the patient's been discharged. For recurrent disease, we really don't have any well-studied antimicrobial therapy for C. difficile. The tendency is that the patient is fine while they're on the agent, And then there's recurrence 5 to 7 days after the agent, whichever you've picked, is discontinued, meaning its antimicrobial therapy effects are gone and the patient's spores are reacquired or regerminate within the gut and cause recurrent infection. And that can occur within a week from the end of therapy till even as many as 3 months from the end of therapy with the same strain that caused the first index infection. For a hospitalized patient who's been hospitalized with that recurrence, the focus is on the use of vancomycin rather than metronidazole because of the risk of neuropathy and other side effects with recurrent administration of metronidazole. Fidaxomicin doesn't really have much clinical experience as far as the recurrent patient, but theoretically it can be used just as well as vancomycin. The clinical emphasis for recurrent disease, once you've had your third and greater episode of C. difficile, is to use vancomycin in an extended format. That can come either as tapering therapy, which can have a significant expense associated with it, or as pulse therapy, which actually results in a patient finishing their standard 10 to 14 days of 4 times daily therapy, then going to 1 dose every other to every third day for some period of time, established kind of by the clinician's judgment, essentially. Over that period in which they're on these antimicrobials, that patient will not get C. difficile back. Again, it's the period after the end of therapy at which they are at risk for recurrence, and that's where some newer therapies may come into play. So we live in exciting times for the management of hospitalized and community patients with C. difficile. Certainly the new FDA-cleared agent bezlotoxumab has just come out, showing a very nice reduction in the recurrence risk, about an absolute risk reduction of about 10%, which is certainly not what we were hoping for with that agent, but it's a monoclonal antibody against toxin B of C. difficile. It went through an extensive evaluation through FDA, and the putative mechanism of action, unlike antimicrobial therapy for C. diff, is to simply protect the host from the effect of C. diff toxin B, which we think is necessary and sufficient to cause disease. The other agent I should mention is fidaxomicin, which is a new kid on the block in terms of FDA-cleared antimicrobials for C. diff. It is another narrow-spectrum agent, much like vancomycin, that only kills gram-positive flora as opposed to gram-negatives. So it has a theoretical slight advantage over vancomycin in terms of its recurrence risk with first-time use. And of course, finally, there's fecal microbial transplant, which attempts to restore the native human microbiota to the individual who's had C. diff, with the putative mechanism being that you put the collateral flora back in the gut which defend against C. difficile presence, so that even if you do re-ingest C. difficile challenged by whatever means, re-exposure at home, re-exposure in the hospital environment, you will be protected from having recurrence of disease. The principal logistical barriers to this therapy, which has shown in many trials to be very, very efficacious, is who pays for the screening of the donor. There are certainly donor-derived infections that one is at risk for. Not just the bloodborne pathogens we all kind of think about in terms of blood banking, but GI pathogens, which could be spread directly, fecal-orally. That's how this is administered, either as enemas or as colonoscopic administrations or as feeding tube or capsulized versions of this all exist. And so I'm concerned, really, that we have seen an explosion in the use of FMT with not a whole lot of regulatory guidance from the FDA right now in terms of using it for C. difficile. And that means we're exposing thousands of patients to this therapy without necessarily thinking about the risk of donor-derived infections that are of short-term risk and long-term risk. What I mean about short-term risk is the risk that this therapy poses to the profoundly immunosuppressed patients who are at high risk to get C. diff to begin with. And there I mean inflammatory bowel disease patients who are on a lot of biologic therapies that put them at risk for some interesting infections, solid organ transplant patients who have really, really high incidences of C. diff disease, and BMT patients. So bone marrow transplant patients are a particularly vulnerable group.
The most important thing when prescribing medications to treat C. difficile disease is to understand how severe the disease is. And so there has to be some severity scoring. And there's many methodologies out there as to how to do that. The one thing I will say is the first person who described it was Czar, and in the Czar study, the problem with the way that they classified mild versus moderate to severe was just a 2-point system. And so essentially 1 point was for age over 64, and so or over 60, so if you were old, which many of our hospitalized patients are, and had any one of the other factors listed, like an increased white blood cell count or a temperature or low albumin, you hit for severe. And so it really didn't nicely differentiate mild versus severe. It really wasn't discriminatory enough. And so although it gave us our first hint that oral vancomycin might have a place with more advanced disease, no one sort of was ready to just sort of go with that. So subsequently, there's been many other studies which looked at the severity scoring and that sort of thing. And there was a study that was actually to look at a newer antimicrobial to treat C. diff, which was Televimur, which never made it to market. But that study was actually sort of the best one, or the best first one, to better severity score. What they looked at was metronidazole, vancomycin, and the Televimur. And in the sort of second round of testing, the Televimur didn't do well at all, and so it never made it to market. But what it really showed us was that oral vancomycin is better for folks with severe disease. And so now the guidelines suggest doing some sort of scoring, whether it's a point system or just looking at the conditions in which patients have. At the University of Pittsburgh, we did a scoring system where you had to have 4 points to sort of qualify as that more severe disease. And it's really, really important to understand what you're treating so you can have the best outcome. Now, the most important thing about all of the severity scoring is to recognize when your patient is really sick, so severely severe sick. And the guidelines call that severe complicated. And why that's important is because besides what antibiotic you pick, you need to get your surgeons on board. Sometimes the procedures in which are necessary for C. diff disease they're surgical. So what happens with C. diff is the toxins are produced in your gut and they give you this chaotic inflammatory reaction. And sometimes the only way to stop that is to actually remove part of the colon or to be able to get to the colon and infuse the therapy directly. And so the two procedures that are utilized historically was the colectomy, where you actually just cut out the whole colon. Worked and can be life-saving, but then you're left with no colon, and that has a lot of side effects on its own. The next procedure is one called a loop ileostomy, which actually one of the surgeons at the University of Pittsburgh, Brian Zuckerbrome, I'm going to give him a little thumbs up, I think was instrumental in utilizing to kind of get these patients from that really high inflammatory state to a much more suppressed state. And what happens is you take a loop of the colon, you bring it out, you put the vancomycin in, distill it in there sort of locally, and you don't really use that part of the gut until they completely cool off, and then you could hook them up later. And so not only is it life-saving, they end up with their colon at the end. And so Brian's been very, very successful with the loop ileostomy procedures. So severity scoring to get you into, do I use metronidazole? Or do I move to oral vancomycin right from the get-go? If I'm severely complicated, not only do I want to use oral vancomycin, the problem is I'm afraid I can't get it down there. And so we also give IV metronidazole in combination with that. And if you're really concerned that the gastrointestinal tract isn't working, you can instill the vancomycin perirectally, so from the bottom. So for the vancomycin, the most important thing is that it's sort of topically treating the infection. The IV metronidazole is given intravenously and will get into the colon, but the IV vancomycin would not. And so we have to make sure that we give it directly to the colon, and then that can have its action. Sort of the final step in that, which we're really only using now for more relapsing, is the fecal transplant. And the fecal transplant has been shown to be used for severe disease as well. However, because of lots of FDA and other restrictors, it's not yet come into clinical practice. And I do hope that with time and evolution that we find more use for FMT. Recurrent disease is very problematic, especially for the person who has it. If you have one relapse, you're in this position where you're at an increased risk for the next relapse, and you can see how this just becomes problematic one after the other. We have patients who can no longer have any quality of life. They have no activities of daily living. They, sort of depend on other caretakers for everything in their life. And it's really, who would want to live like that? And so these are our most problematic refractory patients. And so for them, we have little to offer. We've tried the vancomycin, the extended courses. We've tried the pulsing and the tapering of the antibiotic, and it works to some degree, but sometimes we find that right when we stop the prolonged course, they come back with another recurrence. And so these are the people that if we could fix one population, it would be them. And so some of the wishes of the infectious disease community would be to have that sort of magic bullet to affect recurrences. And some of the newer antimicrobials, like fidaxomicin, I think really set out to do that. And so when studied and looked at efficacy for initial C. diff disease, it didn't really do much better than oral vancomycin. And so that's probably not its niche, but where it may have a niche is in preventing these recurrences. I mean, clearly, if there's anything we can do to sort of interrupt that cycle of recurrence, it would be great. There's other things that can be done. There's antibodies, monoclonal antibodies that are being utilized, and they've actually shown reduction in patients who've had first-time disease, sort of the group that got it versus the group that didn't. And there was a significant reduction in the folks that got the antibody. And I think that's good too. It's a one-timer, so you'd have to get it again. That antibody doesn't last forever. But I think the real answer is going to come with vaccine. So for me, vaccines are always the answer when they're available, even greater when they have a really good efficacy. I would even take one that had a 50% efficacy, and you 60 years old, stand in line and get your C. diff vaccine. Lord knows I will be in that line when it's my time, because if we could even just prevent some of this bad disease in the elderly, we would be so much better.
The recurrence risk of an individual C. difficile patient is difficult to predict accurately, but the risk factors for recurrence almost exactly mirror the risk factors for getting the disease to begin with. We're talking about things like age greater than 65, use of antimicrobials not aimed at C. difficile, particularly the fluoroquinolone class, are tightly associated with recurrence risk. End-stage renal disease patients, presumably because of their increased chronic contact with healthcare settings, but we don't really know. And the length of stay which is predicted for that individual patient. So if you've got an allogeneic bone marrow transplant patient, for example, who's in the very beginning of their conditioning, you can guarantee that they're extremely high risk for recurrent disease compared to somebody who's in for just an inpatient infusion of chemo and they'll be gone in 2 days. So you've got these risk factors that can help guide you in the risk for recurrence. What you don't have as a clinician is really a great toolbox of therapies that have differential outcomes to pick based on that risk. We would love to have that kind of toolkit, but we just really don't. We do have a couple trials to guide us in terms of what you should do if you have a first incident C. diff infection. We know that fidaxomicin may have an advantage over vancomycin if you're treating somebody's very first C. difficile infection in terms of the downstream recurrence risk for that individual patient. The other thing to think about is what other therapies beyond antimicrobials might be useful for the management of a patient at very high risk for recurrence. So if you're seeing a patient who meets all the risk factors I've outlined and has already had 2 or 3 recurrences of C. difficile prior to seeing them, the number of prior recurrences being a very potent risk factor, you know that they've got nearly 100% chance of C. difficile recurrence after the end of therapy. Some clinicians take this to mean that we should extend vancomycin therapy for longer. Empirically, we don't have great evidence to suggest that should be done, but it's commonly done, and it's also done with fidaxomicin if the costs can be overcome in some circumstances. The other new therapy to think about, of course, is the monoclonal antibodies against toxin B, now FDA cleared as besletoxumab, that has a downstream recurrence reduction of about 10%, seen in its randomized trials. Definitely an agent that could be considered if you've got a patient that's at very high risk for C. diff recurrence, and this is a non-antimicrobial route to reduce that risk for this individual patient. And of course, there's also the still very much understudy use of fecal microbial transplant. The tempering statement I should make about fecal microbial transplant is the recent randomized study of Hota and colleagues, where they showed that extending vancomycin didn't do any better than fecal microbial transplant in terms of the recurrence risk for the patients enrolled in that trial. A lot of us believe that happened because the transplants were being administered almost 2 days after the end of vancomycin therapy, which may intoxicate the FMT given to the patient. FMT is commonly given at varying degrees of time distance from the end of therapy. And we know that vancomycin isn't fully excreted from the human gut until at least 7 to 8 days from the last time you take a dose. So that's an open question in the field, is if FMT will do better if it's given farther from the end of therapy. But that also means that it shouldn't be considered in the management of patients in the hospital with acute C. diff infections if they're still on any other therapy for C. difficile. Whether it's metronidazole, vancomycin, fidaxomicin, we don't have much data for any of the non-vancomycin drugs, how long each of these agents is excreted from stool once given to patients. And that's going to be an area that needs to be studied before even thinking about giving FMT as a therapy. And so for recurrent disease patients, you've really got two options. Give a trial of fidaxomicin or give a trial of extended vancomycin with the potential, if you have it available to you in your area, to do FMT if either of those fails at some point after the end of those therapies. So my institution faces a number of challenges in managing our house-wide C. difficile rate as well as managing individual patients. The challenge for individual patient management is the fact we do not have a very wide toolkit for managing recurrent disease, other than extending vancomycin therapy beyond the usual 10 days of therapy or trying fidaxomicin. So the other challenge we face as an institution in terms of managing our house-wide C. diff rate is you've got all these components we know work to control epidemic C. difficile, but what do you do about endemic C. difficile? Every American hospital has some rate of C. difficile that we accept as the inevitable consequence of care in an American hospital. Is that as good as we can do, right? In an institution my size, it means that we're accepting that we'll have about 100 to 200 patients a year get C. difficile from our institution, even though we're at well below an epidemic rate that's been described at many institutions. Can we get that to zero? I think the challenges we face in the future getting to zero have nothing to do with what we treat C. difficile patients with, because we know that C. difficile patients are not the source of most C. diff infections. It's the asymptomatic colonized patients. There are some things on the horizon that give me some hope. One is a Canadian hospital that did a trial of asymptomatic carrier identification. They actually used a PCR on rectal swabs on all admitted patients to find those who were colonized. And they put patients they found having positive C. diff colonization into what I call contact precautions light. They had the healthcare providers interact with these patients only with gloves on and using soap and water hand hygiene rather than alcohol disinfectants. Beyond that, they didn't do any of the other things we associate with C. difficile isolation precautions. We did not cohort them together. You could be a C. diff colonized patient roomed with a non-C. diff colonized patient. You did not have to wear gowns. And they didn't do anything special with terminal disinfection in that study because they actually already used a house-wide agent active against C. difficile spores. And that hospital saw a significant reduction in their endemic rate of C. difficile. Not to zero yet, but much closer than they started. And we await to see if this could be replicated elsewhere, even if it comes to doing randomized crossover trials to see if that same approach might work. I think the challenge with that, though, is that won't work if you're already having an epidemic of C. difficile. If you haven't gotten your hand hygiene rates up into the 90s, if you don't have compliance with contact precautions and have it moved to a house-wide disinfectant that works against C. difficile spores, doing extra measures such as finding carriers is nice, but it's not going to really do anything to one's C. difficile rate in all likelihood. So there's a lot of moving pieces to C. difficile infection control, and that's really the main challenge, is making sure the old paces are adequately maintained and then considering expanding to these new pieces in C. difficile infection control as we get those old pieces well maintained and well running.
We and the rest of the world suffer from the same problems. We know exactly what to do. We know exactly how to do it. We have great guidance on what to treat. We still have some, sort of probably some ways to go with the best therapies, but the problem is compliance. So we know what to do, but we don't get people to do it. And so from the infection prevention standpoint, again, you have to not only write it down on a piece of paper that this is your policy, you actually have to get it upheld. And the issue in healthcare is there's not always accountability. If there's not compliance with a measure that is policy, there's really not necessarily repercussions. And so I think we as a country need to step forward and say, I really mean it. If I tell you you must clean that room with a sporicide, if I tell you you must wash your hands with soap and water and wear the garb, you must do it. I mean, if we had Ebola in that room, they'd be doing it. So I think that all of the illnesses that threaten us as a country need to be respected, and that we need to get compliance with all of the measures that we know work, that we know should be in place. Resources are an issue. So I talked about the sporicidal agents. They can be more expensive. The other thing that I wanted to mention is they have a side effect profile. So lots of times folks immediately say they smell different, they stink. The newest one, the peracetic acid and hydrogen peroxide, smells like vinegar, and folks dislike the smell. They like the smell of bleach, but bleach has the added problem of it's corrosive, and so it damages your equipment, it makes your environment look not nice because it sort of leaves spots and stuff. so folks don't like to use them. You must. This isn't a debate, this isn't, a question of what we should do or when we should do it. You must. And so that's the accountability that I'd like to see in healthcare, and I just don't see it. As far as treatment, I still think that I would hope by now there's awareness. This disease has been plaguing us with severity and deaths and colectomies since 2000. I would hope that clinicians realize that this is a respected illness and that you should pick appropriately based on severity scoring and make sure the patient gets all of the duration of treatment. But I still think that we find gaps there, that when we, especially when we change episodes of care, going from an inpatient acute to a long-term or to an assisted living, we sometimes don't have that follow-through where the duration of therapy goes with them. And so they leave and they don't get any more and they're back next week with a relapse. And so I think that we suffer from those challenges, and it's basically all about compliance.
The things I would most emphasize to institutions facing a C. diff outbreak is, one, don't go into denial. It probably has nothing to do with change in diagnostics or change in antibiotic prescribing habits. It probably has to do with some aspect of infection prevention that isn't going as well as you had wanted. There are definite lapses that occur, and those need to be identified and corrected if you're having an epidemic. For the clinician caring for C. diff patients, I think there's a lot of consternation about the overdiagnosis issue, both for outpatients with these community-acquired diarrhea testing modalities we're offering, as well as with the PCR test compared to the older EIA tests, which are clearly more sensitive and are at risk to identify C. difficile colonized patients. There's always going to be a role for physicians in managing C. difficile infection, because there is nothing that the laboratory can do to distinguish a C. diff colonized patient found by this PCR test that one has ordered from the C. difficile infected patient, other than clinical judgment. Does the patient have leukocytosis and abdominal cramps and fevers and clearly has secretory diarrhea from an inflammatory state, or are they on tube feeds and are colonized and you found it by PCR testing? One pearl I offer clinicians is, if you can't tell or you're undecided, treat them. You have little to lose, other than that you can cause colonized patients to get disease with vancomycin in an old trial. That's not likely to be an issue for a severely ill patient. But if they do not respond to therapy at the end of 7 to 10 days of anything, they probably don't have C. difficile. If they're taking vancomycin, fidaxomicin, metronidazole for 10 days and there's been no empiric response at all to their diarrhea, they have something else, and you cannot stop at this is, quote, refractory C. difficile. In my mind, that does not exist. And I think focusing on the patient and their diarrheal complaints and what's causing it is far more productive than casting around for an alternative therapy to the one you've chosen, or to go into fecal transplant for someone who's not, quote, responding to C. diff therapy. If it's C. diff, it'll get better with standard antimicrobial therapies. It just doesn't last. They will recur once they're off those therapies. And I think that's a very critical distinction, because we see in all clinical trials for C. difficile a 10% non-response rate in all the arms. And that means that even in our well-designed clinical trials for C. diff treatment modalities, we're seeing patients enrolled in those studies that are not infected with C. difficile, because we don't see 10% of people just dying and exiting life because they didn't get the right C. diff drug. We're seeing people that got diagnosed with a test for a disease they probably don't have. And so that's, I think, the most important thing to remember is that clinical judgment is critical in managing patients, and there is nothing the lab can do to substitute for that clinical judgment.
So I think that people have to come to realize that prevention is really key. And so all of the methodology that's in place with barrier precautions and effective cleaning and dedicated equipment must be utilized, or we're never going to break this transmission. We're never going to know about unidentified cases, and we're going to see this going on and on and on. So I think that's imperative, and it's not about, sort of how or when, we must. The next sort of thing is the antibiotic stewardship. I still don't think we have full penetrance in this country, and I see antimicrobials, sort of misused all the time. There's no restriction necessarily. So I think that many hospitals have become the leaders in antibiotic stewardship and have done a fabulous job in reducing, especially the offenders. There's really no reason to use clindamycin anymore unless you have certain conditions like necrotizing fasciitis. There's really lots of times in which you can take a very broad spectrum antibiotic, and once the microbiology susceptibilities are back, pick a much less offensive agent with a very narrow spectrum. We need to get much better at that. And I'm not quite sure why that hasn't taken off, because not only do you get amazing outcomes, with C. difficile, you save money, you get less side effect profile with allergic reactions and other things. And honestly, like the whole multi-drug resistant organisms is kind of a problem because of the misuse of antimicrobials. So there's so much gain to be had with that. I really don't understand what's the resistance and why, practitioners don't sort of do that more routinely.